First of all, I would like to extend my gratitude to BrosMed for organizing this PCI Balloon Studio. With me are three distinguished guests from our region, a little slightly further away, Dr. Şevket Gogulu from Turkey. And then we have Dr. Sarnan from India and Dr. Mahmoud from Egypt. So I think the idea about this webinar is basically to share the range of balloon products that BrosMed have, which I think adds on to our armamentarium of tools that we can use, especially when we're dealing with complex PCI. So I'm going to kick this off by sharing a few cases before passing on to the next speakers on how some of these balloons have helped me in my interventional work. So if you allow me, we'll just share my slides.
Yeah, okay.
So I've got a few cases to share.
Okay. Yeah, Dr. Jaya, you can share your screen now.
All right. Okay, cool.
Yeah.
Okay. So I unfortunately in my institute I do not have the Artemis balloon, the semi-compliant balloon yet. Oops, wrong spelling. Okay, so I'm going to share a few cases of mine who I think have greatly benefited from some of these products. So just as to start, complex intervention requires a large armamentarium of tools. Be it from simple semi-compliant balloons, non-compliant balloons. Now we have, scoring balloons, cutting balloons, and especially when dealing with calcified and long diffuse diseases, we need more specific tools to help us. And when it comes to left main bifurcation, besides the stenting techniques, besides imaging, we need better balloons to help us achieve that, and that's where the pod balloon comes in, which is a fairly new player for me at least in Malaysia. So and with the advent of drug coated balloons, we need more robust preparation of the vessel to ensure that we have optimal immediate and follow-up results. So we don't want to badly dissect a vessel that we intend to treat with drug coated balloon and end up having to put a metal in it. So I will jump straight to my cases, and we'll see how some of these balloons have helped me treat my case. So I have a 74-year-old lady, hypertensive dyslipid, presented with recurrent typical angina with preserved LV function. So if you can see her angiogram, fairly normal left main, some minor disease in the circumflex, and mild to moderate disease in the LED, which is calcified, and she's got a tight proximal stenosis in the right coronary, slightly abnormal origin, and I'm not sure if you can appreciate it. The lesion is actually a little calcified. So I was thinking about it. Initially, we didn't know that the RC is that tight, because when we used a diagnostic catheter, it wasn't very visible. So when we took the SAL guide, actually the QFR for the RCA shows that it's 0.75. So what I did was, I knew I was going to have a lot of trouble with passing stuff down. So in fact, very early on, I took a guide extension, and you can see from the first image on the left, the Wedge NC balloon passes down very nicely. I mean, obviously I've had very good support, and it's opened up quite fully. I went up to quite high pressures here, but I still wasn't very happy, because I know the lesion's a bit calcified. I don't want to have a underexpanded stent, so I went up with a 3.0 NC, and at 80 atmospheres the Wedge 3.0 actually burst. So if you can see, there's a little bit of staining of the contrast, actually the 3.0 wedge burst. So then I decided, I said, let's take a Apollo NC 3.0, and that went up to high pressures very nicely, and I was quite happy, and I knew that, you know, the stent will go down quite easily. So a 3.030 drug coated balloon was applied, post dilated that with an Apollo 3.5 NC, and these are pretty good results. The post QFR is 0.96. So even the 3.5 NC Apollo went down quite nicely in this lesion, but obviously I've had good support, so there's argument to that. Yeah. Okay, so I move on to the second case. 47, fairly young gentleman, diabetic dyslipidemia, had a recent anterior MI with a reduced ejection fraction. So if you look at his coronagram, his left system is fairly horrible, very diffuse disease, you know, some disease in the left main. If you're going to stent this, you might not have much place to land the stents, and it's so diffuse. We actually offered him cabbage, but you know, he was not so keen. Fairly large right coronary, some disease, but giving retrograde to the LAD and the circumflex. So my intention for this patient was actually to open up both these totally occluded vessels, hopefully not having to put any metal in them, bring him back in about 6 months and see what's going on with the vessel. So that's how we did. We managed to cross the first vessel, which was an OM3 with a Fielder XD, pre-dilated that with a semi-compliant balloon, and then again we had to use the Fielder to cross the second OM, pre-dilated with a 2.0 wedge. We were quite happy with that results, and we put in drug-coated balloons in the OM2, a short one. In the OM3, 2 long drug-coated balloons, 2.2530 and 2.530, and the immediate post results, and you know, were pretty decent, I felt. So I accepted that. Went on to the LAD. This time we used the same Wedge NC 2.0 and took a new Wedge NC 2.5. One thing I find with the Wedge is the rewrapping is pretty good. So I've had patients who had to treat, you know, triple vessels using the same Wedge NC 2.5, and it has not given me much trouble in terms of, you know, passing down the lesion or crossing a tight lesion despite it being used, despite it being winged. So the rewrapping of the Wedge NC is actually pretty good. So again for the LAD, I just put a drug coated balloon, a 2.530, and we achieved very good immediate results. Usually, you know, after a drug coated balloon like this, I tend to wait 5-10 minutes to see if there's a acute closure, and that did not happen. So I'm actually going to bring this young boy back in about 6 months and see if there needs more definitive treatment to see if his vessels have grown, and take it from there. All right, so third case, this is a much elder gentleman, a 77-year-old diabetic hypertensive, had a previous stent in the LAD 20 years ago, presented with a non-ST elevation MI and ejection fraction of about 45%. So this is coronary angiogram, large left main, large circumflex, some diffuse disease, very large right, you know, some sort of diffuse disease, but nothing critical. So I decided not to treat the right coronary because obviously the symptoms were coming from the LAD. So we went in, managed to cross a wire into the diagonal, balloon the diagonal with a semi-compliant, and then we decided to take a cutting balloon initially for the LF anterior descending, but as you can see, it did not really open up very well. Even though thereafter we decided to take a scoring balloon and went up high pressures, and that did the trick. It opened up the vessel quite well. But we kept losing that diagonal. You know, we use a semi-compliant, comes back for a while. So at this juncture, actually, we were thinking whether should we put a drug coated balloon, or because it's quite an old stand, should we just stand across it? There was quite a lot of recoil. Even Ivor showed that. So we said, we just put in another DES. We put a 3.528, and we had a lot of trouble trying to rewire the diagonal after that. So what we thought that so we took a pot balloon. So we pot that diagonal. We accidentally actually pull out the diagonal wire. So we pot the diagonal with a 4O pot balloon, and then pre-dilated that LED further. And thereafter, the cyan blue wire actually went down fairly easily. So, and then we pre-dilated the diagonal again, did some kissing with a 3.5 NC and a semi-compliant. And then based on Ivers, we again took a pot with a 4.5 pot to finish up. And we thought the results were fairly decent, and patient has been pain-free since. So the pot balloon is very interesting. I kind of like it, to be very honest, because I think we achieved better pot with this balloon because of there's not much of a wing to the balloon, so which is good. Now, the last case, just a 72-year-old gentleman, diabetic hypertensive dyslipidemia, again came in with typical angina, preserved LV function. So you can appreciate it's got a left main, some calcification in the left main, very large circumflex, tight proximal osteo LED, and if you can appreciate the calcium around there. Some disease in the right coronary in the mid segment. So this gentleman, from the word go, decided to do some arthrectomy. So I actually proceeded to do an orbital arthrectomy. I felt that would give me the best clearance. But you'll be actually surprised that the ring calcium, which was not at the ostium, rather it was about at the proximal LED right after the visible calcium. So there was a 360 calcium actually further down, in fact, rather than at the osteoproximal. So after arthrectomy, you can see the Wedge NC opened up very nicely, 2.5, but with all my calcified lesions, I especially vessels that I know are large, I'm pretty afraid that it would not open up fully. So I always prepare them to my heart's content. So then I took another wedge, a 3.0 wedge, and I was quite happy that I knew the vessel will open. So on Ivers is actually a very large vessel, 3.5 to 4, 4.5, and a 5.0 left. So initially we put in a 3.533 DES, post-dilated with a 4.0 Apollo. The diagonal flow was good, so I didn't bother very much to kiss. Stented the left main to LED with another 4.023, and then this is the immediate after results. And we took again a pot balloon. This is a 5.0 pot balloon. Did a proximal authorization to the circumflex, and then post dilated the rest of the stent with the same balloon. And really beautiful results at the circumflex. Not much pinching, and I did not have to do much work after that. This is the final results. So I have to say I'm quite happy with the pot. But if there is one complaint I have about the pot, is that it takes a little while to deflate. If any of the other speakers have experience with the pot balloon, it takes a little time to deflate. So you have to be a little patient after deflating the balloon. Don't just try to yank it out from the catheter. We've run into some problems with it, to be honest, but that is probably one little trick. You just got to be a little bit patient. Pull it back. If it's not going into the catheter, just give it a little time. It should come back. So just a quick take-home message from me from my talk. Treating complex coronary lesions, to be very honest, a simplified, the advent of the tools like the scoring balloon and NC balloon, which has obviously been around for a long time, and now the pot balloon. And obviously not all lesions are the same. So, different tools are necessary at the discretion and experience of the operator. And of course, it's good to be familiar with a few, expert of a few, but it's important to know all that is available as to not limit the option of the patient. So I thank you. And as we go along, feel free to shout out questions. If there are any now, I can take them. If not, let me see. All right. Okay. If there are no questions now, what I will do is, as we go along, all of us can share to answer the questions. So I will not, hold up much time. And I will.
There's one question from audience.
Oh, okay.
Yeah.
Sure. Is somebody going to read out the question to me, or how does this work?
Yeah, and the question is from the chat
right.
box. Yeah. Cool. And Dr. Jaya, will you always use semi-compliant balloon for pre-dilatation?
Okay, this is a really good question, because when I started training, we always use semi-compliant balloon, right? Obviously, the scoring balloons back then when I started training were like actually cutting balloons at angioscope, flexdome, whatnot. So we don't really go to that unless we cannot open up the vessel. So it's semi-compliant, non-compliant, and then we had the ultra high pressure balloon, the OPN balloon. So what happened was, this is a personal experience of mine. Somewhere towards the end of my training, I sort of shifted into a DCB believer. So what happened is I wanted to DCB most lesions, and I automatically shifted to a scoring balloon from the offset. Unless, of course, the scoring balloon refused to go down, then I use a semi-compliant balloon to open up the lesion, right? And then I actually score almost all my lesions, because I feel that lesion preparation is really good with a scoring balloon. It doesn't matter what scoring balloon you have. And it gives me a good opportunity to apply drug-coated balloon if the immediate pre-dilatation results are good with your usual restenosis of less than 30%. Now, having said that, scoring balloons are not exactly cheap, right? So if you're in a lab where you're not at luxury for this, so most people use semi-compliant balloons. I know some operators around the region who only use non-compliant balloons. They don't really use very much semi-compliant balloons to prepare lesions. So it's based on experience and, of course, local economy.
Okay, thank you, Dr. Jaya. And we got another question from the audience. It's what's the advantage to use a port balloon compared with common NC balloon?
So the port NC balloon does not have a shoulder per se. It doesn't wing out, right? So there's not much overhang. So it's extremely short shoulder, right? So you get to you actually do a proper port in that sense, because the pressure is applied right at the area or the origin of the branch that you want. So the main advantage is the extremely short shoulder. Yeah. So we've been using quite a lot of it, to be honest. One of my colleagues presented fairly recently where he managed to capture on stent booths after using the port balloon, how beautiful, it's like how when you draw and show someone what a pot should look like, it looked exactly like that, because the left main was huge, and then we used a 3.0, and then we stretched it. It opened up really nicely to the circumflex. So I regret that I did not put up that picture. It's a typical picture that you want to show a pot. That's how you draw it. So that's how the port balloon actually helps to me. The short shoulder is really good. I've got quite good experience with it so far. Yeah.